So this Zoom seminar, we have two distinguished speakers, hoping that His Excellency Dr. Somse from Central African Republic will be able to connect. The two excellent speakers, well known in the field of conflict, war and health. And I'll invite them to make their 15-minute presentations and then take questions and answers after each talk. And at the end of the presentations, we'll have a general Q&A, which we will moderate through the chat line and the Q&A line. I mean, we'll close soon after 6 o'clock with some concluding remarks by Kelechi. So I'd like, because of the connection issues, to introduce the first speaker, to welcome Jabbour, who is a Jewell medical and public health professor in the Faculty of Health Science at the American University in Beirut. So Dr. Jabbour is part of an international collaboration to establish a global alliance on war, conflict, and health, for which he serves as the founding chair. And at the University of Beirut, he has led the Public Health in the Arab World Initiative, and also co-led the Lancet series, Health in the Arab World, A View from Within, published in 2014. So without further ado, I'd like to invite Cymru to take over and do the presentation. Thank you very much.
Thank you, Dr. Jewell, for the introduction, and thank you to colleagues in the network for organizing this event. It's really a privilege to join you. And I'm truly grateful that you have picked up the subject of war, peace, and health for this year's Tony Jewell annual lecture. My interventions was designed to follow His Excellency's Dr. Pierre Somse, the Minister of Health for the Central African Republic. Unfortunately, he's unable to connect now, and we're hoping that he will come in any time. So I will give an intervention that's perhaps a little bit out of sequence, but it still will relay some of the key concepts that I wish to emphasize. Now, Dr. Somse would have spoken about the challenges that countries in Africa experience in relation to wars and on conflicts. And as a matter of fact, the biggest killers over the preceding years in terms of casualties of wars and conflict are perhaps in our region, in the whatever we call it, the Arab region, the Middle East and North Africa, or the Eastern Mediterranean region. And that's why perhaps he and I are on this same panel. But numerically speaking, traditionally and to this day, Africa, particularly sub-Saharan Africa, have had the largest number of active wars and conflicts globally. With the network's focus on Wales-Africa connections, obviously this is a very important issue for Africa to address. And Dr. Somse, who I hope will still join us at some point, would have described to us some of the challenges that he faces as a health practitioner, as a policymaker, as a health leader, in terms of addressing either conflict as an active issue or the consequences of conflict. He would have come from that background of focusing on Africa's issues. I come from the background of looking at the issues of our region. And I will present perhaps a story here that describes how we've moved from working on our regional issues in relation to war and conflict into global action. So I will share a few slides that I have prepared for you, I assume this is working.
Yes, we can see that.
Okay, excellent. So our start in this area was with the project that Dr. Jewell referred to, which is the Public Health in the Arab World. This was a large international collaboration that included a couple of books, articles, a network that now has a couple of thousand people, and this collaboration included some attention to the area of war and conflict. Obviously, this is a long-standing issue in our region. So you couldn't really look at health in any particular sub-region of this vast region extending from Asia all the way to the Atlantic without actually running into the issue of war and conflict. But by the time we actually kind of wrapped up one of the phases of this conflict, we find that conflict became a big issue in our region with the promising Arab uprisings that called for democracy and change in the region. But unfortunately, that all descended into conflicts, brutal wars, and tremendous misery across the region, particularly in my home country of Syria. So during this period, as we wrapped up the first phase of the Public Health in the Arab World, we felt the need for a re-examination, and we looked at the Arab world in the context of change, and part of the examination concerned war. So 2 out of 5 examinations that we carried out actually focused on war or war-connected issues such as environmental survival and sustainability, major issues connected with the wars in our region. By the time we wrapped up this project in 2013, the war in my country had really escalated and became news all over the world, and therefore we had to really then focus our effort on examining the war in Syria and its health consequences and actions about what needs to be done for Syria. This led us to launch the Lancet AUB Commission on Syria. Thanks to the amazing leader, the editor-in-chief of the Lancet, Richard Horton, who believed that Syria is a subject of global importance. He saw it not as a local conflict, but as a conflict of profound regional and global consequences. And it was true then, because Syrian refugees by then had been thrown all over the world, and Syria was no longer a local issue. As a matter of fact, from very earlier on, Syria was not a local issue. Syria very early on became an issue of geopolitical positioning and competition, and then the spilling over to the region, and with refugees to the world, and with the involvement of the world in Syria. 4 of the 5 permanent members of the UN Security Council were actually in Syria fighting and doing other things, and there were people from over 70 nationalities fighting in Syria. So this initiative led to all sorts of initiatives, scholarship, policy. We brought the issue to the UN General Assembly as a side event, all sorts of other advocacy, and I invite you to visit the website that would tell a lot more information about this. Now, as we were examining the issue of Syria, we started asking questions about the field of conflict and health in its global dimension, and this will bring me to the part of the talk that I was supposed to focus on, which is really the global dimensions and the global aspect, building on the African challenges that His Excellency Dr. Somse would have presented. As we were asking questions about conflict and health globally, we made several observations. We asked, for example, what are other countries, particularly low and middle income countries, doing in relation to conflict and health? And obviously, we found out very quickly that there are very few institutions like our faculty, which are based in countries affected by war and conflict, which are actually doing a lot of work on conflict and health. This field was dominated by centers of excellence in Europe, the UK, North America, Australia, but the global South, where the majority of conflicts are, is really not in a place where it's involved in leadership in this area. They're not the experts being called. They don't generate the bulk of research, and I'm going to show that in a little bit. There are the field itself is underdeveloped. I mean, if you look at journals, for example, in the area of conflict and health, you'll find two main journals that are focused on this area: Medicine, Conflict and Survival, and Conflict and Health. But you take urology, you will find 22, perhaps more. And there's a lot more that that we can say about this, but every place where you look at the scholarship, you will see a tremendous need for growth in this field. We didn't see many collaborative platforms. We asked ourselves what would be an example of a network or an association or whatever entity, collaborative platform that we can ourselves join, so we learn from others and we collaborate and try to address what the issues we were facing, but also work together to address the issues we're all facing together. We didn't find many. There were small networks, again, focused on specific issues, but not platforms that address the issue in its global dimension. We really didn't think that there was serious global leadership in this area. We appreciate greatly the efforts provided by organizations such as MSF, ICRC, perhaps UN agencies in addressing the humanitarian health needs of people affected by conflict, but that doesn't equate to a serious work on conflict itself that addresses all of its dimension, from weapons to conflict analysis to the health-related conflict consequences to targeted work to conflict prevention, all sorts of issues that needs to be addressed. And we also felt that the global health community is really not taking adequate, not paying enough attention to global wars and conflict globally, considering the tolls that conflicts and wars have on our societies in general and on health specifically. I mean, wars is our major contributor to our global burden of ill health, to the dysfunctioning of health systems, to deteriorating infrastructure and other determinants of health that determine consequently the health of people and communities. These observations led us to, I'm going to be speaking a little bit later to this particular point about collaborative platforms, which is why I'm highlighting it here. So this led us to carry out a series of work to try to validate these observations that we had made, and I'm going to share with you just selected slides that make the point. In this slide, we see that middle-income countries don't produce, are not the major producers of literature on conflict and health, as you can see. But the countries highlighted in yellow are countries that are considered middle-income countries. Also, Turkey is in a kind of in-between category, but still, all of those, the three countries, are actually in our region. And you know, it's really a very very unfortunate thing that Africa doesn't feature in this list. And Dr. Somse would have discussed some of the reasons why this is the case, perhaps related to institutional capacities, investments, availability of researchers, availability of practitioners to work in this area. Obviously, there's a lot to discuss there, but the reality is that Africa, sub-Saharan Africa specifically, really has a possibility of coming in to contribute more to HADA. And perhaps this is one of the reasons we are having this webinar, is that what are the possibilities that Africa has, conflict-affected Africa has in relation to the field of conflict and health. When you look at the type of scholarship, the type of scholarship, this is based on an extensive research carried out, scoping literature review from World War II up till now, looking at what research has been produced. And as you could see in the line here, I'm not sure if you are seeing my cursor, but the line here, I'm pointing to this, I guess, fuchsia or velvet color that shows PTSD. And I will explain in the following slide why PTSD features so heavily. The research on refugees, for example, is right here. As you see it, it's in this brown interrupted line, accounting for less than 6% of papers, while as you can see here, PTSD alone accounts for over 20% of papers. And when you look at the populations most studied in the conflict and health literature, you begin then to see why this is the case. Is that the active military service and veterans, typically of wars involving UK, US, Australian, other European countries. These are the two populations most studied in the global literature on conflict and health, while the conflict-affected populations and refugees and all of that come third and fourth. So. Even in relation to who's studied, whose suffering are we trying to capture, whose issues are we highlighting, affected populations don't necessarily feature in very high. This is changing a little bit most recently, as we see in this past decade with regards to Syria and elsewhere, but it's a historical observation that's worthy of consideration. When you look at what countries have been studied the most, shockingly, African countries feature in the others category here, but not among the major ones, despite long history of conflicts in the sub-Saharan African region. So this is another, obviously, another opportunity for us to really shed more light on what's happening in sub-Saharan Africa, to really put the spotlight on the challenges faced there. When you look at the issues that are being examined with regards to conflict and health, you will find that there's a limited scope of issues that are being examined. Obviously, this is not. This is just a segment of the papers looking at a small sample, but it still tells a story about what is it that's being examined and what is it that's being ignored. For example, the issues around people's experiences doesn't feature strongly. This field is a lot more quantitative in terms of capturing percentages and all of that, but it doesn't really necessarily accounts for the experiences and narratives of loss and suffering. We found this to be extremely important in our research in the Lancet AUB Commission on Syria. When you look at the initiatives that have been launched over the past 50 years with regards to that connect in one way or another with conflict and health, you find quite a few initiatives. MSF was founded in 1971 in revolting and breaking off from perhaps ICRC. The International Physician for Prevention of Nuclear War here was founded in 1980. And then all sorts of other organizations, for example, Physicians for Human Rights, that really works a lot in the area of conflict and health, was established in the mid-1980s. Quite a few initiatives, but all of those initiatives are essentially not connected with the regions where the problems happen. Again, validating the observation that I had spoken of earlier. On the right, by the way, is what you see, the onset of various conflicts around the world, highlighting several African countries as well. When you look at the record of major scholarship initiatives in the area of conflict and health, again, you find a few really promising ones. The establishment of the Medicine and War Journal in 1985, which eventually became Medicine, Conflict and Survival. Several Lancet special issues devoted to conflict and health. But again, you don't see many initiatives that are actually based in the regions that are most affected by this. We certainly understand the difficulty of this area. I mean, if you want to work in the field of conflict and health, you will find that you really have to draw on a lot of feeder fields. This is a term that we've used to describe this how you really need to account for practice and scholarship in these various fields in order to work in the area of conflict and health. You have to know something about disaster medicine and emergency response. You have to know something about IHL and issues of protection. You have to know about human security, about peace building, about the special fields such as refugee health, mental health, because trauma is a big aspect of mental health, and frequently it's discussed in that field, not necessarily in relation to this burgeoning field of war and health. You really have to understand conflict. So you have to understand conflict studies, have to understand peace studies, and we've actually have gone through the pain of trying to really understand a lot of these various areas. No one can really master any of this, all of this, but you have to be informed to try to understand what takes place in this field. So this led us to in 2018 to call in on a group of colleagues from around the world to ask them to join us in Beirut at the American University of Beirut, where we presented these observations, we presented this research, and we discussed what is it that we can do about these observations we discussed earlier, particularly the lack of collaborative platforms in this area. So then we discussed that we perhaps want to launch an international platform to facilitate dialogue and collaboration on action on conflict and health. First, we actually thought about launching a society, a global society on war, conflict and health. But when we presented this to partners in more than one region, it became quite clear that a society is not the way to go. It was seen as being too academic in a field that lends itself to collaborations, to practice, to policy work, and where a lot of actors in this area are not necessarily academic, but rather NGOs, nonprofit organizations, think tanks, advocate networks, all sorts of partners in this area. This brought us to London back again, where we had the Richard Horton, the editor-in-chief in The Lancet. This shows you how we've kind of completed the circles from working on one issue to addressing the issue in its global dimension. And we agreed to launch this global alliance on war, conflict, and health. I know that the vision of a world without war, health is protected, justice upheld, and peace promoted sounds very ambitious, but this is what visions are. The mission itself is still very ambitious. We wanted to the alliance to be a global community to strengthen action on conflict and uphold justice and accountability as foundations for peace and health. And this emerges from the facts that we see in Africa and elsewhere about how many violations, including health violations, such as attacks on health facilities, targeting of health workers, really go with impunity. There's very little accountability in this area. Only once for a violation in former Yugoslavia, only once were attacks on healthcare brought to justice internationally. So the alliance brings together researchers, academics, practitioners, and advocates who work across the spectrum. And this is something I want to emphasize: is that most work on conflict and health is about cleaning up after war. This is what it is. Most of the work globally is about addressing the need of people affected by war, humanitarian provision, protection, whatever it is, but it's all affected. We wanted to expand the scope. We wanted to also put a bit more emphasis on issues of prevention, but also sustaining, building and sustaining peace, and also looking into the issue of health building during and coming out of conflict. This is a hugely neglected area. Once a country disappears from the international news, with big casualties and destruction. The conflicts typically either smolder on a small scale, or the consequences of are so severe that these countries really cannot get out of, cannot rebuild, and they live in permanent state of fragility and instability. And there's great need for us to, as a global health community, to continue to pay attention to those countries and settings. So the Alliance works through science, collaboration, capacity development, and advocacy to advance this field and provide leadership in this area, and particularly amplifying the voices of those who are living the burden of wars. We set to ourselves two sets of objectives here. One is supporting affected people and communities, and I'm not going to read everything here, but examples is the issue of advocacy to neglected areas, such as we discussed, issues of rebuilding coming out of conflict. But also a second set of objectives relates to advancing the field. We want this to become a legitimate field of global health work, and we want to see leadership in this area that based also on sustainable partnerships and amplifying the voice of those living the burden of war. The Alliance works.
Some more. I think we've got His Excellency Somse has joined us.
Excellent. Then in this case, I'm just going to thank you all for this opportunity to speak to you, and over to Dr. Somse.
Thank you very much. Thank you very much for that. We'll come back to you during the discussion. So yes, let me welcome His Excellency Dr. Pierre Somse, who's managed to join us from Central African Republic, and we're very privileged to hear from you. And I don't want to waste any time by giving an introduction, but just to say that you are a public health trained doctor, and you've had extensive experience in HIV/AIDS particularly, but worked for the WHO and many United Nations organizations, and are currently Minister of Health in the government in Central African Republic. So can I hand over to you now to make your presentation, and then we'll have some questions and answers afterwards. So thank you very much. Over to you.
Thank you a lot, Dr. Tony, and for your patience. I know that time has passed. I don't know how much time I have, but I would just say that I'm very happy. How much time do I have?
Go for 15 minutes. 15 minutes.
Okay, thanks a lot. Yeah, as you said, very well introduced me. I'm a public health expert, now Minister of Health, but I have not lost my quality of public health expert, and it is in with this double quality that I'm speaking on this panel. Thank you very much for inviting me to share with you my perspective. War is a public health emergency first, and thousands of people who are killed in my country, thousands of people who are physically wounded, mentally affected by conflict every year, and which should remind us that war is a tragedy with dramatic negative consequences on health. And particularly because most of those killed by war are in fact civilian. This is true globally and in my country. And this is unacceptable. And for two decades, as you may know, the Central African Republic has been experiencing a complex and severe security crisis with serious human consequences. This crisis has compromised the development process of the country due to pillage, the destruction of economic system and goods, as well as health and school infrastructure, murders and runaways of human resources, displacement of population to areas without health structures or congestion of health structures in host areas, vulnerability to epidemics, disruption of routine vaccination, and other public health emergencies due to displacement of population to areas without basic facilities, such as drinking water, latrine, and sanitation. This situation led to the collapse of health structures in some parts of the country, making the population even more vulnerable to preventable and curable diseases. This resulted in several diseases, outbreaks of disease, including vaccine-derived poliovirus, yellow fever, hepatitis, measles in several health districts. Now we have monkeypox also. During the first 5 months of 2022, only an estimated 69 incidents, attacks on health and humanitarian workers were reported. Mental disorders has become an epidemic. According to the World Health Organization, nearly 1 in 5 people, 22%, who experienced war or other conflicts 10 years ago or less will experience depression, anxiety, post-traumatic stress disorder, bipolar disorder, or schizophrenia. As you may know, Central African Republic has been undergoing a protracted crisis for 3 decades. The issue of mental health is becoming a major public health problem and a cause of loss of productivity, given the multiple political and military crises that the country has faced over the last 2 decades. The real extent of this mental health remains underestimated due to the sociocultural representation that local population have of mental health illnesses, witchcraft, magic, bad luck, punishment of ancestors, etc. The National Mental Health Policy document reveals an increase in the number of new cases admitted to the psychiatric and mental services in Bangui, the only specialized center for treatment of mental health issues, which rose from 416 cases in 1996 to 1,812 cases in 2018. Furthermore, the constant increase in the request for mental health care contrasts with the lack of qualified personnel and above all, the lack of decentralized care structures. War, intra-community conflict contribute to the increase of cases of gender-based violence, in particular sexual violence against girls. Indeed, conflict-related sexual violence has increased sharply in CAR in recent years, and is considered the main security risk for Central African women and girls. In 2001, MINUSCA, the peacekeeping mission, reported 589 cases of conflict-related sexual violence, a doubling of the number of reported cases from the previous year, 240 cases in 2020. Most cases of those conflict-related sexual violence are perpetrated in areas where armed groups are active and concentrated. The conflict have caused also inequality and inequities in distribution of health services, as shown in the distribution of health manpower by region. The capital city of CAR, Bangui, has the largest number of qualified health professionals, with nearly 21 health workers for 10,000 people, whereas the 2 health regions most exposed to armed conflict have each nearly 1 health worker for 1 professional for 10,000 people. The conflict have depleted those regions of human resources. Clearly, several decades of insecurity and political instability have had a devastating impact on the health status of the people of the Central African Republic. As a result, the country has the 2nd highest maternal mortality rate in the world, with 829 deaths per 100,000 live births in 2018. As the Minister of Health for country affected by ongoing conflict and atrocities committed by a rebel group, I witness every day the serious human and health consequences of war. I see it in the cries of those who have been injured or mutilated during armed attack. I see it in the grief of victims of rape, and I see it in the mental health consequences of thousands of women and men raped, as well as children who are orphaned by war, traumatized by the ongoing conflict and its consequences. All those physical and mental health consequences create serious disease burden that require urgent attention by the health system of the Central African Republic. Yet, because of the conflict, the health system of my country is confronted with a serious challenge due to, among other things, to the destruction of health facility by armed groups and attack on health personnel and humanitarian workers. Following the 2013 conflict, an estimated 30% of health facilities were destroyed. Health workers had to flee conflict zone because armed groups targeted them as state agents. Following the military action of the National Army and its partners, as well as MINUSCA, several localities have been freed of armed groups with the restoration of peace and security, offering the possibility for Central Africans who have gone into exile in neighboring countries to be able to return to their region of origin or adoption. The presence of the National Army, its partner, and MINUSCA in this area, which make it possible to temporarily contain the potential inter-community confrontation, is an opportunity to undertake comprehensive action to promote social cohesion. The strengthening of health system in this area is a factor that encourages the return of this displaced person to their village of origin. There, they will have access to quality health services which will strengthen their resilience and ultimately lead to sustainable peace. Bringing healthcare as close as possible to where people live and work is the first element of an effective process of health protection and peace. Health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, is a fundamental human right. Inadequate access to healthcare and lack of equity are source of conflict. The impact of conflict on healthcare system made it also difficult to prepare for and to withstand the shock of pandemics such as COVID-19. But this challenge do not mean that we are powerless. Our resilience to COVID-19 and our determined effort to increase vaccination coverage, to reduce malaria mortality, and to expand access to HIV services in the last 5 years are testimonies to our commitment to advancing health despite the challenge of conflict. Since 2018, we have seen critical progress. Immunization administrative coverage has increased from 44% in 2017 to 80%, and CR has achieved the status of country-free of poliovirus. The proportion of HIV patients on antiretroviral treatment has increased from 25% in 2017 to nearly 60% in 2022. In April 2019, the President of the Central African Republic, His Excellency Faustin Archange Touadéra, launched the 10 presidential priorities for accelerated action toward universal health coverage. These presidential priorities include key health areas such as maternal health, girls' education, vaccination, HIV, TB, malaria control. These priorities strategically locate individual health and the strengthening of health system into broader framework of peace and stability through the human capital development. We have also transformed the health crisis to opportunities for peace building. For the government of CAR, effective health system that serve all population is fundamental to creating and maintaining peace. This has been my mantra as Minister of Health. On my own initiative, taking a personal risk, I have successfully engaged different armed groups by reaching out to them and advocating with them the fact that health facilities, health workers, and humanitarian actors should not be targeted. I have worked closely with humanitarian actors, including ICRC, Médecins Sans Frontières, the Center for Humanitarian Dialogue, and the United Nations to advance this critical view of health as a cradle of peace. I have learned that healthcare system, mainly the hospital, are the mirror of the community or the society, particularly in context of war and conflict. Careful observation of interaction between users and on one hand between patient and health professional can help prevent and measure conflict in the community or in the country. It is my view that dealing with violence should become a discipline and institutionalized function of healthcare management to establish a systematic and predictable approach to problems of violence in healthcare and in the society. The Ministry of Health should endeavor to make the healthcare space a safe haven for all. In this perspective, I have been guided by 4 principles: anticipation, preparation, cooperation, response, and evaluation. We must work together to rebuild and develop the resilience of health system in countries affected by conflict. This is critical for peace, and it is critical for global health and the safety of our world. Thank you for your kind attention.
Thank you very much, Your Excellency. So that's really good news to hear that Central African Republic, sometimes described as one of the world's poorest and most fragile countries, is making progress, as you've described, and congratulations on that. I'd just like to invite the chair of the Wales Africa Health Links Network to respond to our 2 speakers, because he has to nip off in a minute to get a train. So Kelechi, would you like to just respond to what you've heard from the 2 speakers? Thank you.
Yes, thank you very much, Tony. I really appreciate that. And so first of all, thank you so much, the Honorable Minister, for persisting in spite of the technological challenges and eventually making it onto the session, and for that wonderful thought-provoking presentation. Really, really grateful for that. And Dr. Samuel's presentation was excellent and also triggered a lot of thoughts for me. I think it is a very challenging situation when, as Dr. Samuel presented, that the Global South is underrepresented in publications and scientific research and efforts around understanding the impact of conflict on global health. But even within the cohorts of Global South, Africa is even more severely underrepresented, if not completely absent. So I think in many ways it is a bit of a call to arms to redress that imbalance. One of the things that struck me listening to both presentations was the real focus on, and I took this a little bit from the vision that Dr. Jabbour presented. So the vision of a world without war. So, and all of the efforts, a lot of the efforts that the Honorable Minister was describing was in the space of preventing conflict in the first place. And I can't help but present that as a public health physician in the paradigm of primary prevention and secondary prevention and perhaps tertiary prevention, and where there's a lot of focus, quite rightly, on primary prevention. How can we prevent conflicts in the first place? And we get a big win if we can get it right. But then there is also that second question of secondary prevention, that when we fail, if all of our efforts to prevent conflict fails, what can we do to reduce the impact of conflict, that regressive impact of conflict on the national economic and social development pathways in countries, in low to middle income countries? So there is something for me about how do we, when there is conflict, when we've done everything to prevent conflict and it fails, how can we reduce the impact of conflict on the development of less developed countries? Because it becomes almost like a vicious cycle. And I can see a little bit of that, some of that in Dr. Somse's presentation about we can strengthen health systems, because strengthening health systems is one of the ways you may reduce the impact of conflict on social, economic, and overall development. So this is an area that I'm really delighted to receive the presentation. And I hope for many of us, it triggers that need for us to seek to redress that imbalance that was so glaringly demonstrated in both presentations. But thank you so much for that very thought-provoking set of presentations. Thank you.
Thank you very much, Kelechi. You better get off to get your train. But thank you very much for recommending that we do look at war and conflict for this lecture this year. And if people are content, I think we should just continue for another 10 minutes or so, just to have some opportunity for people to ask questions. And particularly, there is a question already about, I think Dr. Somse talked a bit about sexual violence. And the question really says it's a common instrument in war, sadly. And how can this be reduced? Is there any evidence that relationship and gender education at secondary school level, or even in army training, would be worth doing? So that was a question that maybe we'll direct to Dr. Somse first.
Thank you very much. When you look at, closely, when you do a sort of anatomy of, the perpetrator of sexual violence and the circumstances, you will see that you have both educated armed force and not educated, and particularly what happened in a country like mine, that all the armed groups are recruited among unemployed people. Actually, what happened is that because of the protracted crisis that has prevented children from going to school, so you have, a huge number of men and that are not doing anything, that are not being educated, that are not going to school, that don't have employment. It is among those that that the rebels are recruiting. So so they don't have any education. Not because education was missing, but the context of a protracted crisis and preventing any social investment like health and education make them a good candidate for rebellion. They are used to do that, so they do what they are asked to do, and one thing also that we have found, we have seen that, based on the testimony that we receive, is that those people are, they have been given a drug. So the rebels are fed with drug. They use drug in order to make them more aggressive, and so that mentally they are also biased. So you have a conjunction of many factors that are actually constructed to make them the weapon, to make them a weapon. So yes, education is because in cities where you have a good level of education, the rate is not as the same as in the area that are affected by armed groups. So yes, what can you do in this kind of context? I think for me, we should also speak about what is the cause of war. We should speak about the cause of war. Where does war come from? Who are the actors of wars? And those include non-state and state actors. Those include governments. And of course, when you look at the different type of wars in the world, it's always created by government and multinationals, and it's I think for me it's a question that address the moral, it's a moral address the conscientiousness of this world, and of governing bodies of this world, leadership of this world. And for me, I believe that the real cause is that war has become an economy. War has become a source of income, a source of revenue for states, for nations, for multinationals. So the question is, how do we address the conscientiousness of those bodies? How do you, and it is there. So this, we need to address that.
Yeah, thank you very much. I'll just bring Samar in just in a second, but you raised the economic question, and one of the things in the CAR is that you've got lots of natural resources, I think, haven't you? Uranium, gold, diamonds, cobalt, oil, lumber. And that's what you mean to some extent by economics as well. And for many of us in Europe, unfortunately, having to learn about Ukraine and Russia and the war in Ukraine, there's a group called the Wagner Group that we become familiar with. People, Western powers, Eastern powers, exploit war to access and control natural resources. So I think that's a really important question. The other thing I just quickly wanted to say, there's just looking around this issue, that 40 years ago, the WHO, the Health for All, said the preservation and protection of peace in the world is the most significant factor in the attainment of health for all. So that was 40 years ago. And I remember when I first went to public health that there was something called the Public Health Charter, which said security, which gives freedom from war and from the threats of crime and violence. And the question was about sexual violence. And then in modern times, all this has been translated into SDGs, as you know. And SDG 16 says, promote peaceful and inclusive societies for sustainable development, provide access to justice for all, and build effective, accountable, and inclusive institutions at all levels. And what they're saying is that that's one SDG, but actually all the SDGs, as you just described, are dependent on security, freedom from violence, and war and conflict. So this is actually, as you said, is a very pervasive thing, that there's not just one aspect to it. So, Samuel, do you want to say anything about sexual violence in particular and how one might try and reduce that risk?
Thank you. The question that Paul Myers asked is a very important question, but he asked in a very specific way. He asked about the evidence. So I dare not venture into answering a question without looking at that evidence. So I want to see the evidence of whether gender education or army training. But the issues that we are seeing in recent conflicts, where there has been rampant use of gender-based violence, indicate to us that these precautionary measures may not necessarily work if gender-based violence is a strategy of war. So it's a deliberate strategy of war. For example, with what we are seeing in Ukraine, with the Russian soldiers really even touting in public social media about the use of sexual violence. No matter what education they have gone through and or training, you would imagine that that effect has been all erased by the relentless impetus to engage in this criminal war. So. But it's a good question, Paul, and it deserves a serious look at the evidence.
And the people have been asking also about how they join the Global Alliance, and I don't know whether you wanted to say a shortcut for that. I mean, I've suggested the website. Is there an easier way or a better way?
Well, thank you for your interest in the Alliance. The Alliance right now has two types of memberships, the individual memberships and memberships for institutions, which could be NGOs, academics, and whatnot. And there are forms on the website, as Dr. Jewell suggested, that you could fill there. So I direct you to the website, which is warconflicthealth.org. It's all one word. I'm going to put it in the chat for everyone. I guess I cannot write warconflicthealth.org. I will put it for the hosts and panelists, and perhaps because I'm unable to share with the rest of the group. So there's a membership section. Regarding the issue that Gregory Leslie raised, it's an issue that I will defer to His Excellency Dr. Somse, but I will just say that that the working with actors in conflicts should actually expand to not just formal armed actors, but also to non-state actors. There's I'm reminded of an initiative called the Geneva Initiative, which is a group that works with non-state armed actors in many countries around the world, including my country, Syria. They work with them on training them in issues of IHL violations. They sign a charter. They agree with them on signing a charter. They undergo training also. So there's a lot to be done truly with various armed actors. The challenge is that, are we seeing the impact of this of working with actors on the behavior of actors in relation to violation of human rights and IHL? And unfortunately, the answer to this, at least based on the anecdotal evidence, is no.
CRC in my country has been doing work with rebel groups, training them on human rights. So I think there are some initiatives like that which can have some impact in the field. But as you said, Cymru, there is a deliberate approach to making sexual violence a weapon of war, because people want to really hurt. They want to promote fears, to convey fears as also a mean, or to trying to gain, to succeed, and gain access to whatever they want to access, make people flee so that they can free up, whatever place, whatever space they need to exploit resource, or to attack or weaken the public and the civilian mentally, attack them mentally, weaken them, and by the best way to also weaken the power, to weaken the government, or to create a revolt, a rebellion, a sort of among the people. So it's a weapon. It's a weapon. But those who are the actors, the scientific actors of the war, they just devise that, and the intermediaries are the one implementing them, because they recruit the rebel on the ground, give them drug, give them money. They don't have work. This is the only mean that they have to access some status that they would not access otherwise. So, anecdotally, this is what we see. But the question is a very interesting one. for which we need to have evidence. This can certainly be done through some cooperation.
Okay, thank you. There was a question that Samuel just mentioned about peacekeeping troops, that there have been examples in Africa, but also elsewhere in the world of peacekeeping troops actually, abusing the civilians in this sort of way, not only sexual violence, but other forms of violence on civilians. So I don't know what the answer is, but clearly that's another factor. So peacekeeping troops brought in to try and help mitigate, war and conflict are themselves sometimes actors in it. So I don't know whether you have any observations on that.
Yeah, some sexual exploitation are happening, with some peacekeeping groups. This has been, there are some official cases with actually Western peace, both Southern and Western peacekeeping agents, because of course war result always in impoverishing and creating misery and putting people in a situation where they have to sell sex in order to gain some favor or to gain some to gain their life, to gain money. So, and you have some agents that take advantage of that. It's not always institutional. There are some individuals among the peacekeeping mission that have those conduct. It's not linked to the institution.
Okay, thank you.
If I may come in, I think the colleague who raised the question asked an important question, which is who becomes a part of the conflict? And I think we have to agree that there's a myth that being involved in conflict, that there's a way of avoiding becoming part of what political scientists call the conflict ecosystem. When we study conflict, when we provide humanitarian aid to conflict, when we fund humanitarian work or do peace building, all of the actors involved in this, including myself as a researcher, researching, for example, Syria, I become part of the conflict ecosystem. There's no avoiding it. We just have to be explicit about the fact that we have become part of the conflict ecosystem, and we have to be clear about what the implications are of our involvement. So it's whether it's acknowledged or not, there are consequences to what I might say about the conflict in Syria, or what His Excellency might say about the situation in Central African Republic or so. If this is all made explicit and studied and documented, then in this case, we might be in a better situation to account for the totality of actors' involvement and create more or less a scorecard of who's doing what there and with what impact. Over.
Thank you very much indeed. And one of the other things that has happened, and this topic affects civilians, is that, early 20th century, evidently World War I, II, you were getting 10, 15, maybe up to 20% civilian involvement. But in the late 20th century, it became 90% civilian involvement. And I think in the West, obviously, we're seeing in Ukraine that explicit use of civilians in conflict. And it was a surprise to me that Universal Declaration of Human Rights doesn't actually mention and makes no reference to war, except to say the respect for human rights is a means of preventing it. So I think one of the things we're observing in contemporary conflict, both in Africa, Middle East, and in Europe, that actually civilians are part of the conflict, not by choice. So it's not just looking at combatants, and they are the ones subject to this destruction of their houses, their heating, their kids' education, and everything else. So, look, time has kind of moved on a bit, and we did say that we would run over by 15 minutes. We're now 25 minutes. There aren't any other questions coming up on the panel. So I would just probably need to bring this to a close now. I don't know if our speakers want to have a last word on anything before I close the seminar. Dr. Somse, do you want to say anything else before we end the meeting?
No, just saying thank you for bringing to light this question and creating a space for research practitioners and policymakers to talk about it, because by talking about it, we can little by little, certainly create a new consensusness.
Thank you. Thank you. Cymru?
Thank you, Tony. I will actually comment on your last comment. I think it's important that we pay attention to civilians, but the contrast between studying actors involved from high-income countries, what I showed in one of the slides about how veterans and combatants are studied. These are typically the soldiers, American soldiers, UK soldiers, all of that, versus the complete, and I will emphasize, complete lack of attention to combatants, to the health, in our case, because we are global health workers, to the health of combatants from countries involved in conflict. I think this creates a certain inequity that we have to try to redress in global health work. Those are typically combatants drawn into these conflicts. But not by choice, but they're forced whether by governments or by rebels. And these are people who have families and whose suffering is also ignored. And I'd like to perhaps point to that inequity and the need for further work to address it.
Yeah, thank you very much indeed. So, let's bring this to a close and thank both our speakers for joining this evening. There were excellent presentations, and this is a very, very important public health priority. And we will see how we can take this forward by making contact, obviously, through the Global Alliance, which I think both of you are engaged with. So that will be a way of ensuring that we don't just talk about this and forget about it. In fact, we can't forget about war and conflict, because every day we read about it where all sorts of parts of the world. So thank you very much for joining us this evening and giving us your insight into your expertise and so on. And we will try and find a way of following this up positively with you in the future. I'd like to obviously thank Dr. Kelechi Nnoaham, who had to leave early, who was chair of the Wales Africa Health Links, and particularly to Beth Kidd, who both of you will have seen how hard she works behind the scenes to try and bring this event to our listeners and participants. And Beth works for Hub Cymru Africa, and behind Beth is an organization particularly of partners and volunteers interested in peace and health and working with diaspora communities in Wales. So I'm going to say farewell to everyone and have a good evening wherever you are. So thank you very much and good night.